Hello, everyone. Um, Hope this finds you well. I would say good afternoon because that's when I'm recording this, but Lord knows when you're going to be viewing this. Uh, Today's lecture is going to be about the New York State Emergency Medical Services System, the roles and responsibilities of being an EMT, the well-being of being an EMT, and some key medical legal concepts that we need to cover. And I'm going to be going back and forth between some PowerPoint slides and seeing me, and we'll have a graphic coming up in a little bit. Obviously, this is being recorded, so if you want to see it again, you will be able to. This is going to be a challenging time for us. Obviously, we know things are different right now. So we're going to see how this goes. I have no idea how long this lecture is going to take. Normally when we're in person, we have live questions, things like that, and things get drawn out a little bit. But we'll see how it goes. So anyways, I'm going to be sharing my screen, going back and forth a little bit, and we'll get started. And hopefully my dogs don't interrupt me too much. All right, so we'll go to the next slide here. And I will be posting the slides and anything that we produce here on the Google Classroom when it gets around the time that you would be watching this. Some of these we're going to be recording several days ahead of time, Rob and I, and some might be just the day before, who knows. And anything that we do live on Zoom, we're going to record those as well. And anything that we share, we'll post on Google Classroom, so you'll have a hard copy of it if you want to have it. So let's talk about the Emergency Medical Services System. It starts with a patient and how that patient gets access to emergency medical services. How does one get access? And normally the answer would be they call 911. And we'll talk more about that down the road. But yes, they're going to call 911, and the dispatcher is going to interrogate that caller. It sounds like a harsh word, but that's what we do. And there's several key questions that they're going to ask. And as you know, I'm a part-time 911 dispatcher. But we want to find out initially, where are they? And it's not just their address, but where are they in the house? Are they in the basement? Are they in the attic? Are they out back? Did they fall out of a tree? Did they go down the stairs? Are they laying in bed? And how do we tell our responders, where to get access to that patient? So whether it's the patient calling themselves, or, a bystander or a relative, or someone just passing by a car accident, somebody has to call and access the system by calling 911. The dispatcher then will send the appropriate response. Now, part of that interrogation the dispatcher does is to determine the severity of the call. And again, it's not always accurate because, you're relying on people screaming and hollering and swearing at you as a dispatcher, which every time I work, that's what happens. But they're always saying, just get the ambulance here. But we need to find out where they're at and how bad they are. And we triage patients on dispatch into 3 different categories here in Chautauqua County. We can either call it a BLS standard call, basic life support standard, which means we can respond no lights and sirens. That's the stub toe, fell down, went boom, and I'm not sure if I'm hurt or not, that sort of a thing. The second category is BLS priority, basic life support priority. So that requires a lights and sirens response. That's something a little more serious, but doesn't necessarily need to have like somebody at the level of a paramedic respond. And the third category is advanced life support. Those would be your difficulty breathings, not responding, chest pains, possible strokes, things like that. And those require an advanced life support response, which might be a different system that you have. You may have medics in your department, and they're going to go with you. It might be that you have no medics, and you're going to go, and someone's going to send a medic to back you up. So those are the first responders. We'll talk a little bit more about the levels here in just a minute. Excuse me. Also part of the emergency medical services system is the healthcare facilities that we take patients to. So part of our system is emergency rooms, hospitals, specialty centers, or places where certain patients go. For example, if you're having a stroke, you might go to a stroke center. If you're having a cardiac event, you may go to a cardiac center, that sort of a thing. They're part of our emergency medical services system too. And the EMS system is very complex. It has a lot of parts. I'm going to show you a graphic here in just a minute that will kind of show you what we're talking about. But You're going to see it's a very complex thing in order for us to deliver emergency medical services. Now, our middle name is medical, emergency medical services, which means that we have something called medical direction. We're not just cowboys out there doing what we want. We are told what to do by physicians, and those physicians are called medical directors. They write our protocols, which is basically a cookbook that tells us what to do when we come across certain situations. And that's something we call offline control, offline medical control. So it's not in real time. They get involved with our education. We're going to probably have a doctor, probably be Dr. Falk, show up one of our nights when you're there, just to introduce himself. He's the medical director for our course. He's also the medical director for the 2nd and 3rd Battalions in Chautauqua County. We also have online medical control, which is in real time. Now, in Chautauqua County, we have 2 points of medical control. One is at UPMC Chautauqua, and the other is at Brooks Memorial. So if you're out in the field and you're on a call and you run across something you're just not sure what to do, or it doesn't fit nicely into one of our cookbook protocols, if you will, you can call and talk to that doctor in the emergency room and receive medical direction on what to do, as long as it's within something we call your scope of practice. And I'll talk about that in a few minutes as well. That's online medical control or medical direction. Okay, so offline is protocols, training, things like that. Your medical director, every squad has a medical director. Every department, every ambulance service, you have to have a medical director. That's required. Those sorts of things are kind of like offline. Okay, they're done ahead of time, or they're part of training, or they're part of evaluation. Okay, what we do gets scrutinized by our medical directors, by the health department, the New York State Health Department, and a variety of other people. So everything we're doing is being reviewed to make sure that we're still doing what's right and we're doing the correct thing. Communications is also part of our EMS system. We need to talk, and we need to have the dispatchers tell the ambulance crews where to go. The ambulance crews need to talk to the hospital before they arrive so the hospital can get ready for that patient. Very, very important, and that's not an easy thing. We have towers and radios, and down the road we'll be talking about the radio systems and communications more. But communications is a big part of the emergency medical services system. If we can't talk to people, we can't get to a patient. We also transport people. That's a big part of our job as well. The big part is taking care of them, providing care, but we also have to get them somewhere where they can have, a higher level of care. So transportation is important. So we have to have vehicles. We have ambulances to transport. We could have fly cars that might bring advanced life support help out to us. And those ambulances have to have a certain amount of equipment that's required by the state health department. So transportation and ambulances, again, is a big part of our emergency medical services system. Also part of it is law and regulations and policies. Now, the law in New York State regarding emergency medical services is something called Article 30 of the New York State Public Health Law. And that's a statute, that's a law. So when you're asked a question down the road, what's the law or the statute that governs emergency medical services in New York State? Your answer would be Article 30, okay? So if you know anything about civics, yep, we have a law. It was passed by both houses of the legislature, signed by a governor, and that's our Article 30. Then we have to have regulations that tell us how to apply that law. So for example, Article 30 will say there shall be ambulances. Regulations will then say, okay, to be an ambulance, you must have this, that, and the other thing. You have to have X number of bandages. You have to have oxygen. You have to have oxygen masks. You have to have this. You have to have that. That's in regulation. And those regulations we call Part 800. Okay, it's got a big long title, but we just call it Part 800. So part of Part 800 talks about what has to be on an ambulance. Article 30 will say there shall be EMTs, okay? The regulations then say, okay, to be an EMT, you have to do this, this, and that. And that's sign up with the state, take an approved course like you're taking right now, and then pass that course and pass hands-on practical exams and the state written exam. So the law is Article 30, regulations are Part 800. Then we have policies and sometimes memorandas. New York State Health Department has a long list of policies, and it addresses a variety of things that are in regulation, but maybe not specifically spelled out. And there'll be a variety of things like that. We'll talk more about policies as we go through the course. And as I said earlier, evaluation is a big part of what we do. People are looking at us. Not only are we in a fishbowl, we go to a car accident at 3 a.m, you'd be surprised how many people show up to watch you. And so they evaluate us. We're being evaluated by our medical director. We're being evaluated, by the state, and we're looking at data. And are we doing the correct thing? So that's a big part of what we do as well. So the next thing, I'm going to share my screen and go back here for a second. As I said, the emergency medical service system is pretty complicated. And I'm going to throw a slide up here, and I don't want you to get too hung up on it because it's really involved. And there's people that have been in emergency medical services for probably 20 years that don't understand this. I understand it because I lived it. Okay, I was on the New York State Emergency Medical Services Council for many, many, many years, appointed by the Commissioner of Health. So I'm going to throw the slide up here, and I'll kind of go through it a little bit. But again, don't get hung up on it. It's pretty complicated, okay? And this is something I came up with a long time ago, and the state liked it. I used to call it, on the top right there where it says New York State EMS system, I used to call it the New York State EMS, like it's a mess system. So at the top, our biggest concern is the patient, okay? And then the direct point of contact for that patient is us. We're the EMS providers, the agencies that we're in, as well as the dispatchers who are talking to the patient or the bystanders who are calling for help. Over on the left-hand side is our medical direction side of the system. So our receiving hospitals, like I said, UPMC, Chautauqua, and Brooks can give online medical control. That's over there. We have our agency medical director for each agency. There is a system medical director. We don't have one per se around here. We have two in our system. We have Dr. Falk and Dr. Walters, and they kind of share duties for Chautauqua County. But beyond them is something called the Regional Emergency Medical Advisory Committee, or REMAC. And that's a group of physicians that are medical directors representing the 8 counties of Western New York. And they're the ones that write our protocols, that cookbook thing I was mentioning. They're also the ones that can take us offline. If we do something wrong, they can tell it. They can't take away our certification as an EMT, but they can tell us you can't practice because we're practicing under the license of our agency medical director. We're like physician extenders. We're the hands, eyes, and ears of that physician out in the field because they're not. Excuse me. And beyond that, we have a state emergency medical advisory committee. That's a group of physicians representing all areas of the state. I'm actually a non-physician member of that committee. And they write state protocols and deal with a variety of things at a higher state level. That's just a quick overview. Down the center, we have county councils. We do have a Chautauqua County Emergency Medical Services Council, and they deal with assisting with training, assisting with making sure things are done correctly, at our local level. And then we have regional EMS councils. And in our case, the regional council for us is called the Southwestern Regional EMS Council. And that's made up of representatives from Chautauqua, Cattaraugus, and Allegheny counties. Now they have some statutory authority. And by that, what I mean is they have functions that are legal that they have to undertake. If someone wants to start a brand new ambulance service, that has to go through them. There has to be a public hearing. They have to prove need. You just can't start up an ambulance because you want to, okay? You have to prove need at some point in time before you get that ambulance, unless you're a municipality, and that's a whole nother story. So we have regional EMS councils. There are several of us from Chautauqua County that sit on that council. Above that council is the New York State EMS Council, which I was mentioning earlier that I've been a member of for forever. And they also have statutory authority. Let's say a regional council approves a new ambulance service at their level. And then someone says, I don't think that's right. I don't think they proved need. I don't think they did this correctly. that person is allowed to appeal that, and that appeal comes up to the New York State EMS Council. And all the members of the State EMS Council are appointed by the Commissioner of Health, okay, and ultimately by the governor. When I got appointed multiple times, your name goes to the governor's appointment office to get cleared. And they have to vet you and make sure you're not, you know, a criminal and all that other sort of good thing. On the right-hand side is like the enforcement side of things. So we have area EMS offices. Our area office is the Western Region. They're based in Buffalo. And we have a representative that's dedicated to us. His name is Don Trepaz. And he's the one that comes out and inspects your ambulance service every 2 years. He'll go through your ambulance, make sure you have all the things that Part 800 said you had to have, the regulation says you have to have. You'll make sure all your paperwork's in order, that you've been doing your PCRs or your written records correctly. And he has the ability to fine you. If he finds that your department's deficient, you're going to get a statement of deficiency and you may get fined. And some of the fines can be pretty hefty. Let's say you screw up as an EMT, you did something wrong. We're going to talk about negligence here in a little bit. They can take away your EMT card and fine you, okay? So don't get scared by that. It doesn't happen very often. Happens downstate quite a bit in the city, but not around here. Also on the right-hand side, we have program agencies. They also assist the regional council, they assist agencies, and they work directly also with the Department of Health in Albany. And the program agency for our area is called STEM, Southern Tier Emergency Medical Services. And they're based in Olean. And they cover, again, the 3 counties of Chautauqua, Cattaraugus, and Allegheny. And if you're doing paper written records in your department, that's where you send those, okay? And then we have the Department of Health Central Office, which is up in Albany. They're the ones that produce EMT cards, handle all sorts of everything else, okay? So again, don't get too hung up on that. A lot of people don't understand it. I'm just trying to give you a glossy overview. This document I will post on Google Docs. On the back, on the second page, I'll just show you real quick. There is a little bit of wording here about what each of those, some of those levels are. So you can just review that at your leisure, but you're not going to get tested on, you know, something about the Regional EMS Council. But you have to have an understanding that the system is very involved, okay? So we're going to go back here. And then we'll go back to the PowerPoints. Okay, where are we here? Okay, so different levels of EMS in New York State. The lowest level is below you guys. And that's certified first responder. In other parts of the country, it's called EMR, or emergency medical responder. In New York State, we just chose to call it certified first responder because we had been for many, many years. That's usually for, you know, police officers, firefighters that want some initial first aid training so they can provide some level of care prior to an EMT arriving on scene. The next level is EMT, and that's obviously the course you're taking. That's the basic level provider that is required to be on an ambulance when transporting a patient, okay? So you're going to learn all sorts of things in this course. We talked about those the other night, but that's the basic level person that has to be on an ambulance when it's transporting a patient. Once you become an EMT, you can take any of these other 3 levels. You don't have to go through all the steps. You can go right to a paramedic class once you become an EMT if they'll accept you. Many paramedic courses are, you know, require you to have like a year's experience before they'll accept you as a student. But advanced EMT, you learn more about patient assessment. You learn how to start IVs, to give fluids. There's just a few drugs that they're allowed to give, and they can do some airway management to help keep the patient breathing. Another level is EMT critical care. That's pretty much going away. They're not doing any new courses for that, but there are still some critical care people out there. It's an advanced level. They can start IVs, they can give medications, they can monitor hearts, and do advanced airways and things like that. It's kind of like in between an EMT and a paramedic. Paramedic is the highest level of pre-hospital provider. They start IVs, they give medications, they do 12 lead EKGs like they do in a hospital, and they read them, and then they can provide treatments based on what that's showing. There's other advanced airway things they can do. We can insert needles into a chest to help reinflate a collapsed lung, a variety of things like that. So paramedic is the highest level of regular EMS provider. Once you become a paramedic, and it's the highest state level in any state, but there are other classes that you can take, become a critical care EMT paramedic, which would be like for taking really, really sick or injured patients from one hospital to another. They have a whole variety of all sorts of tubes and that gadgets stuck on them, things like that. But paramedics do those transfers right now. Okay. So those are the levels of EMS in New York State. So let's talk about the roles and responsibilities about being an EMT. You have a great responsibility to your community and especially to the patients that you treat. And never underestimate that responsibility and never take it lightly. So the responsibilities we have, first of all, is safety. Our own safety comes first, then the safety of our crew, then the safety of the patient, and the safety of bystanders. Whether we're at a car accident scene, and a lot of EMTs get injured at a car accident scene because some knucklehead is not paying attention to the fire police that are trying to direct traffic. So we have to make sure that we establish a safety zone and make sure there's an ambulance between us and the patient. We're well off the side of the road. If we're facing oncoming traffic because we're on the other side of the road, turn your headlights off so they can see. Otherwise, you're going to blind them. Things like that. Safety is paramount. You may get into a situation in a house where your safety is in jeopardy. And we'll talk about that in just a minute too. Another responsibility and role that we have is to gain access to our patient. And it's not always gaining access in a car, at the time of an accident. It's also, are they in the basement? Are they in the attic? Are they hanging upside down from a tree because they half fell out of their deer stand, something like that. So we have to gain access to our patients. Then we do patient assessment. We check them over head to toe, take their vital signs, listen to lung sounds, a variety of things like that, and then come up with a treatment plan to care for that patient. Sometimes we get involved with disentanglement. Now, we don't do extrication. There's a split level of responsibility at certain scenes. We are EMS. Excuse me. Rescue is rescue. Fire is fire. Police are police, okay? EMS does not get involved with extrication. We don't use hearse tools and pry doors open. That's what rescue does. Now, in many of our departments, we have joint functions. Yep, I might be an EMT, but I might also be trained in how to use a hearse tool. Okay, that's fine if you have the training to do that. But if you're pure EMS, your responsibility is care of the patient while extrication is taking place. So disentanglement for us could be, getting them out of the bathtub because they fell and they can't get themselves out, things like that. But when it comes to heavy duty extrication and rescue, that's the function of people who are trained to do that. Again, some of us are dual trained for those things. That's fine. But pure EMS is care of the patient. You might be in the car with them while they're trying to extricate. You're covering them with a blanket while they're breaking windows or moving, trying to cut metal so they don't get hurt, things like that. Another responsibility, obviously, as we mentioned earlier, was transportation. We got to get them to the hospital, okay? We have to communicate, and that's communicating between our fellow responders, our other EMTs, communicating with medical control if necessary, communicating with the hospital so that they know what we're coming in. We just don't say we'll be there in 5 minutes, okay? We got to tell them what we're bringing. Are we bringing a stroke? Are we bringing somebody that might be having a heart attack? Are we bringing somebody that has just been sick for 3 days? Okay, they need to know so they know what type of room to get ready, okay? And then we have to transfer care to the next level. We don't just go into the hospital, find a bed, slide the patient over and leave. We have to give a report. That's required, okay? And that hospital has to know that you're there, okay? Otherwise, it's something we call abandonment. And I'll talk about that in a minute. And a really important thing is we need to be an advocate for the patient, okay? Make sure they're safe, make sure we're not doing any harm. One of the first rules of EMS is do no harm, okay? So we need to be an advocate for that patient. If we see something that's going bad, maybe they're starting to carry somebody down the stairs and you see that somebody's gonna trip and fall carrying that patient, that patient's safety and care is your first priority, period. Doesn't matter if you think, well, he carried them, if they're going to get sued, the guy that was carrying them is going to get sued. Everybody gets sued. And they're going to say, why didn't, if you saw this was going bad, why didn't you intervene? And you should have, okay? So we always need to be an advocate for our patient. Some of the traits about being an EMT, obviously you need to be physically fit and able to lift and carry. And there are some things in regulation that talk about, you know, being able to lift 250 pounds with a partner. But you need to be fit. You know, if you can't walk up a flight of stairs without getting winded to go see a patient, that might be an issue, okay? You have to be able to lift and carry patients because they're not all going to walk to our ambulance, okay? They need to be carried out. You need to be resourceful. We're going to teach you a lot of things in this EMT course, but it's all in a classroom setting. We're going to do some scenarios and stuff down the road here, probably with the ambulance simulator over at All-Star. But I can't teach you everything. I'm going to teach you principles, and we're going to teach you techniques. The principles are the gotta do's. Principles are the things that have to happen. Techniques are how we accomplish those principles, okay? So one of the principles, let's say we're talking about a broken bone. One of the principles is to immobilize it so it's not moving around, so those broken bone ends aren't damaging soft tissues and blood vessels and nerves. And we need to, that was a dog, yep. No woofing. Maverick, that's enough. So the principle is to immobilize it. And there's different ways to do that. We can use a cardboard splint, we could use an air splint, we could use a vacuum splint, board splints, there's a variety of things. Principles are the gotta do's. How we do that can vary. There's more than one way to skin a cat, okay? As long as the cat gets skun, I like to say. Not sure if that's grammatically correct, but anyway, that's what we say. So that's part of being resourceful. What application? We're going to teach you a few, okay? And you're going to find that different instructors are going to do things a little bit differently. So, you know, you might be putting somebody onto a backboard, which is, you know, a carrying device. And someone will say, well, you got to tie their feet together so they don't fall off the board. Okay, fine. The other instructor doesn't do that. Those are techniques, okay? Some of those are going to be personal preference things. Doesn't mean they're wrong. It's the principle of using that as a moving transfer device, okay? That's what we're really looking for. We're going to give you a couple different techniques for each thing. The other part of being resourceful is, again, as I said, this is a classroom setting. We're going to do some scenarios. However, keep the principles in mind. I cannot teach you how to take care of somebody who's in a car that's overturned in a ditch full of water and the water's rising. That's something you have to figure out, excuse me, and be resourceful at the moment using the principles and the techniques that we teach you throughout this course. That's what we mean by being resourceful. You have to be able to lead. You have to have initiative. The first day you get your EMT card, you may be in charge of a patient call. So you have to have the initiative to do that, okay? And you may have to lead others that aren't EMTs, even though they may have been around a while, okay? You need to be pleasant and cooperative in front of patients and coworkers and hospital staff. You know, you don't want to walk up into a patient and say, well, what's wrong with you today? Okay, and that's not going to set well. That's not going to set well. You need to have good moral character. We're going into people's homes quite often at the worst times in their life sometimes. And they weren't prepared for us. They didn't expect this to happen. You know, there might be money laying around, there might be medications laying around, things like that. You know, we don't need people going out there and grabbing a fistful of dollars off the, you know, the countertop while we're going to take care of a patient. That's totally inappropriate, or stealing their medication. We need to be of good moral character and above reproach. That's our responsibility to our community and our patients. Need to be emotionally stable. I mean, if you faint at the sight of blood, probably being an EMT is not a good thing, okay? We all have calls that give us trouble. For me, it's kids, excuse me, bad kids. There's nothing worse than, you know, having a SIDS case or a young child's been hit by a car that you're doing CPR on. But you have to do your job. You have to look around and say, there's nobody else here that can do this, then I need to do it. I need to take a deep breath, step in and do it. I can break down later. I can get mental health later. You know, we have stress debriefing teams, we have peer counseling, things like that. We need to take care of ourselves, but we also have to be emotionally stable in front of our patients. And we need to be empathetic. And it's not, we don't want to feel sorry for these people. We want to feel with these people. They don't want pity, okay? But you need to understand what they're going through. And that's empathy, okay? Understand what they're going through. Try to make everything as best as you can for them at the time, okay? And that's empathy. All right, well-being of the EMT. As we said, safety is number one for us, right? Our safety, then patients, then crew, bystanders, or crew, patients, bystanders. We need to protect ourselves from diseases, as we all know, in the current times. Pathogens are disease-causing organisms. So you need to know what a pathogen is, disease-causing organism. And we need to separate ourselves from these pathogens. And we do that through a process we call body substance isolation. Some people call it universal precautions. Right now in EMT, we're calling it body substance isolation. So you're gonna hear the term BSI a lot. And the way we do that is through PPE. Something you may not have heard too much about before, but I bet you have in the last 8 months or so. So we have a variety of PPE available to us. We have like surgical masks, we have HEPA masks, high efficiency particulate air filter masks. And those are called for us N95s. There are different ones, but we use N95s. So 95% of whatever, you know, gets filtered out. We also have goggles or face shields. We obviously have gloves. We don't use latex gloves anymore, but your department might buy latex gloves. So if you have a latex allergy, make sure you find out about that. And we have gowns that we can wear to protect ourselves. Anytime there's going to be any significant splashing of stuff, whether it's blood or secretions, you know, things like that, you want to have all the personal protective equipment on that you can. In today's day and age, until we have a vaccine and treatments for COVID and things like that, every patient encounter, you're required to wear a mask, a face shield, and gloves. If it's a known COVID that you're going to be transporting, then you have to wear that N95 mask. And you probably want to put a gown on as well as the gloves and the face shield. And there's regulations about that. OSHA, that's the Bloodborne Pathogen Standard, 1910-1030. We also have the Ryan White Act, which requires every department and agency to have a privacy officer, so that if you get an exposure, and you know, taking care of a patient when you have all your PPE on is not an exposure. We're talking about getting stuck by a needle, somebody coughs in your face deliberately that you know has TB and you didn't have a mask on or goggles. Those sorts of things are considered probably exposures. Excuse me, the Ryan White Act says every department has to have a privacy officer that you report that potential exposure to. And then they contact the receiving hospital where that patient went, and then there's follow-up that goes along with that, okay? And then there's engineering practices. If you end up, you know, down the road, we're gonna teach you how to give an IM injection, intramuscular injection for epinephrine in case of a severe allergic reaction. You know, part of the engineering practices is you have a sharps container that needle goes into when you're done. So you don't lay it on the squad bench, you don't lay it on the stretcher. It goes immediately into a red plastic bucket, if you will. It's called a sharps container, so it doesn't poke anybody else. We also have biohazard bags in our ambulances, and you should have them in your jump kits that you take inside a house. So that if you have bloody bandages or something, you're not going to leave them at the scene of a house in somebody's living room. You need to take them with you and put them into a biohazard bag. Those things are engineering practices, things that'll try to keep us safe, and so we don't contaminate somebody else. Excuse me, drink of water here. Okay, scene safety. All sorts of hazards are out there, right? Can you think of any? And if we were live, I'd make you go through a list of things, but there's a lot of things. We can go to a car accident where there's wires down, there's fuel leaking. We can go to scenes of violence. You know, you go to that domestic violence call, maybe the police are there and they're handling one side of it, and then somebody comes out of the woodwork and tries to hurt you. We talked about cars at traffic accident scenes not paying attention. We have rising water. We have animals in people's houses that, oh, this person, this dog never bites anybody. He's kind. Well, yeah, and then you're doing something, you're taking care of a patient and they go, ouch, that dog may not like that. And that dog may bite you. So we always try to tell them, put the dog in doggy jail, put him in another room, get him out of here. We run across people that are high on drugs, they're drunk out of their gourds, a variety of things. We could have high angle and low angle type things where, patients half a down cliff or they're up on a roof when they collapsed. There's all sorts of scene safety issues that we have to think about out there. And again, our safety comes first. So every department needs to have a safety officer. We try to keep ourselves safe. We wear the ANSI level 2, lime yellow vests out there so people can hopefully see us, that sort of thing. If your feet are on the street, there needs to be a vest on your chest, okay? Or that some sort of high level visibility outerwear. Be observant, avoid tunnel vision. It's real easy for us to get all jacked up, high on adrenaline, going into a scene, and we're not taking in the big picture. We tend to focus. We get tunnel vision. Keep your eyes looking around you. Okay, scene safety starts before you even get there. It starts on dispatch. What's the weather like? I'm not going to go 90 miles an hour in a blinding snowstorm to get to a call, right? Avoid tunnel vision. Keep looking around, okay? Hopefully nobody blindsides you with things. One of the last EMTs that was killed in New York State, it was up in the North Country. They went to a call for a patient requesting a psychiatric evaluation. So he wanted a ride to the hospital. He was despondent or whatever. So this guy and his partner were in one room taking care of the patient. The patient excused himself to go into another room for a moment. And while he was in the other room, they heard him rack a shotgun. So they turned to hightail it out of there. Unfortunately, Mark is a big guy, much bigger than me, and didn't make it out the door and got shot in the back and killed. So you never know what something's going to happen. Sometimes you can see that something may happen, and you need to have some sort of a code word between you and your partner and your dispatch. And at All-Star, what we use is something I call the purple box scenario. Now, let's say we're on a call, it's me and my partner, and all of a sudden I see a handgun within reach of that patient. And the patient's maybe a little whacked. Maybe he's on some, recreational pharmaceuticals, we'll call it. I don't know what's going to happen. He may snap at any second. So come up with a code. We're not going to say, get on your radio and say, get the police here, there's a guy with a gun, because he may just grab it right then, okay? You need to try to keep things low key so you don't trigger this person, no pun intended. So we do something called the purple box scenario. We're going to get on the radio, call dispatch and say, excuse me, we need someone to bring the purple box down here. And the only time we use that code is when we have urgent security need. Okay, we don't know what's going on. There's something wrong here. If I need a police officer because somebody wants to sign off and I need a witness, we don't use the purple box, okay? We tell them what we need. If I'm afraid that my saying something is going to trigger somebody or a bystander who's saying, don't let him die and holds a gun on me type of thing, use a code word. Nobody carries a purple box. Our boxes are not purple, our jump kits. So that's something that they're not used to hearing, okay? Immediately our dispatch will call, we have a drop line to 911 and say, hey, we got a crew, they just used the urgent security code. I don't know what's going on, but they need somebody down there now, okay? And then we do radio silence, and once a minute, our dispatch will call and ask if they're okay. They'll just say, hey, you guys 10-4, 10 or 1080, some people say, whatever. Just to make sure we're still talking to them. Nobody gets on the air and says, what do they got? Okay, or anything like that, because we don't want to trigger anything. Let's say you're in there and you see something going on, and you can tell your partner, hey, go out to the rig and get the purple box for me, would you? Because maybe the partner isn't seeing what you're seeing. that gets that person out of there. And then that person go out and say, hey, we need the purple box here. Okay, I don't know what's going on. My partner gave me the code and I got my butt out of there. Okay. One thing you don't want to do is turn to your partner and say, you stay here. I'm going to go out and get the purple box. Because now he has no clue what's going on. He or she has no clue what's going on. Okay. So come up with a code word. We like purple box. Something to keep our people safe and get out. You never know what's going to happen. I went to a call one time, and it was a call. We'd been calling this guy before. He was a short guy, kind of handicapped, and he had some health issues. So we get there thinking, oh, it's just another sick, Fred's sick again type of thing. And this lady opens the door for us, and she goes, he's in the bathroom. And so we start walking to the bathroom, and from inside, he hears that we're here. And he goes, she shot me. She shot me. I just violated one of the most important things is now I have this lady between me and the door. And it's like, oh boy, you can try to never let your means of egress get blocked. Egress meaning get out of there type of thing. So, and I see there's a bolt hole in the door to the bathroom. And now we're looking around, and she's standing there. She doesn't have a gun. She's just standing there with this disgusted look on her face. Well, what happened was they were having a domestic argument. They were older, like my age now. And he went in the bathroom and slammed the door shut, and she pulled a gun out and shot through the door. She actually shot him. It went into his chest, but it kind of like went between his skin and his ribs. It actually went out through the bathroom window and lodged into the roof of the garage, which was like 2 feet from that window. And they actually recovered the bullet. So I'm like, holy crap, So we got the cop. She wasn't causing a problem at that point, but we didn't know what was going to happen. And she's standing between us and the door. So we were able to call and get the cops. This was before we had the purple box scenario. That's one of the things that triggered us to do this. And she had thrown the gun underneath a couch is what it turned out to be. So we were lucky in this case. Try not to get your means of egress, your way out of there blocked, okay? Do the best you can for that. Stay safe. Some medical legal terms. Again, we mentioned Article 30 of the Public Health Law. That's the statute. The New York Codes and Compilation Rules and Regulations, Part 800. Again, we just call it Part 800, that's the regulations. We have to adhere to vehicle and traffic laws. Okay, especially when it's regarding lights and sirens, we always have to proceed with due regard for others. Just because we're allowed to speed, we're allowed to go through a red light, you still stop. Then proceed if the way is clear. If you go through a red light and hit somebody, guess what? They're not getting charged with failure to yield. You're getting charged nowadays. Okay, so keep that in mind. We'll have links to these things for you down the road so you can actually read these things. And as I mentioned before, we do have policy statements that we have to abide by that the Health Department, Bureau of EMS puts out. This is the link to the Bureau of EMS's webpage, and there's several pages within this. You are going to need to become familiar with this website. This is where the protocols are published. This is where the policy statements are published. This is where Part 800 can be viewed. Article 30 can be viewed, a variety of things. This is a website that's one of the most frequently visited websites in the New York State Health Department overall, more so than some hospital based websites. So again, this PowerPoint is going to be put up on Google Classroom, so you'll be able to click on the link and then save a bookmark for it. All right, standard of care. The standard of care is what each and every one of us has to meet. The standard is just like it says, it's a standard. It's a floor, if you will. The standard of care is a doctrine which basically says an EMT treating a patient in Chautauqua County, let's say with chest pain, that patient, if they were in Suffolk County, would be treated the exact same way by an EMT in Suffolk County. That's the standard. And how do we create a standard? It's based on your training, it's based on ethics, and it's based on protocols. And protocols, that cookbook thing I mentioned. So the protocol says, okay, you come across a patient with chest pain. You're going to put them in a position of comfort. You're going to loosen any restrictive clothing. You're going to provide them with oxygen. You're going to give them, we carry nitroglycerin as basic EMTs, or you can help a patient with their self-administration of nitroglycerin. We carry aspirin as EMTs. You're going to give them aspirin, things like that. Those are all the things that you need to do. Those are all outlined in protocol, okay? That's the standard of care. That's what you have to meet. You cannot go above that, okay? You definitely can't go below it. Next concept is scope of practice. This is what we're allowed to do. Now, as an EMT, do you think you'd be allowed to do brain surgery? No, obviously not. Do you think you would be allowed to put a splint on? Yes, of course. So somewhere in between, there's a line, okay? That line is your scope of practice. That's what you've been trained to do and what you're allowed to do based on your protocol, okay? You cannot exceed your scope of practice. You may be a nurse, but if you're functioning as an EMT on a rescue squad, you're not a nurse, you're an EMT. You can't do nurse-related things that are above the scope of practice of an EMT. A duty to act, that's your responsibility to care for a patient. If you're on duty and you get called to a scene, you have a duty to act, okay? If you're a volunteer and you're responding to a call, you have a duty to act. It's a legal obligation to provide care. That's absolute, okay? If you're driving by a car accident and you choose to stop, you don't have to in New York State. Some states you do. In New York State, you choose to stop and you're an EMT and you kind of look and say, well, I got to get to work. I'm going to leave. You breached that duty to act. You created a duty when you stopped. Someone else that might have been an EMT could be passing by and say, oh, Fred's there. He's an EMT. I'll just keep going. And then you leave. Oh, bad thing. When you leave, we call that abandonment. It's also abandonment if you take your patient to a hospital, throw them on a stretcher, and then leave without giving a report to a nurse or an aide, letting them know that that patient's there now. That's abandonment when you leave a patient like that. We also have to obtain consent from every patient that we treat, and there's several different types of consent. The initial, if we have a wake and talking patient, consent to start with can be, actual consent, expressed consent. Hello, Mr. Jones, or walk up and say, hi, my name is, Ron, I'm from Salt Run Fire Department. What's your name? Okay, Mr. Jones, is it okay if I take a look at you? And they say yes. Okay, that's expressed consent. Sometimes we need to do things. We're going to put a splint on it. Well, even if we do something like take a blood pressure, it's okay if I take your pulse. Can I take a blood pressure? Okay. And they say yes. That's informed consent. You're telling them what you're going to do, and they're saying, yep, it's okay. So expressed consent is, yep, look at me. Informed consent is you want to do something to them, and they're okay with that. Okay, and that can just be verbal, that's fine. They don't have to document anything at that point. Any alert, mentally competent adult can give consent, okay? Sometimes the patient's unconscious and they're not able to give us verbal consent. In that case, the law allows us to treat that patient under what we call implied consent. The law assumes that were they conscious, they would want treatment. So you can go ahead and take care of that person that's not responding, okay? Minors under 18 or incompetent adults cannot consent or refuse care. They're not mentally competent to do so. So, and patients have the right to refuse. You could have a person that's totally alert and, they're bleeding like a stuck pig and they're saying, nope, don't touch me. Guess what? You don't touch them, okay? You can stand by and wait till they pass out and then treat them under implied consent. But as long as they, adults have the right to refuse care. Okay, as long as they are alert and mentally competent, okay? Anybody that does sign off, refuses medical care has to be alert. And we'll talk more about that down the road when we talk about communications and documentation. There's a whole mess of things we got to figure out when it comes to somebody refusing. Refusing medical care is one of the biggest reasons for lawsuits in emergency medical services. The reasons we get sued. Negligence. This is quite a concept. Negligence is the basis for all civil lawsuits. Torts, they're called also. So you're going to get sued. It's because you were negligent in some fashion. Excuse me. So negligence is its whole subset of legal things. There are 4 points that need to be proved for someone to prove negligence in court. First, they have to prove that you had a duty to act. You stopped at that car accident, okay? You know, you were responding with your fire department to a call and you got there. You had a duty. So they would have to prove that you had a duty to act, okay? The second thing they'd have to prove is that you breached that duty. Sorry, just had a little interruption there. So they have to prove that you breached that duty, and either you did something you shouldn't have, or you didn't do something you should have, okay? Then they have to prove that harm occurred, that patient was harmed, and that could be an emotional harm. It doesn't have to be a physical harm. And then the fourth thing is we call causation, which basically says the harm occurred because you had a duty to act and you breached that duty. We tied it all together, okay? That's for regular negligence in a regular lawsuit, okay? Now, a lot of us are volunteers. If we're responding as a volunteer, there's a little bit of extra protection for us. The law says in order for us to lose a lawsuit, it doesn't say we can't be sued, but in order for us to lose a case against us, they would have to prove either gross negligence or willful misconduct. That's not defined. That's case by case. So one could argue that, you know, I was on a call and it was my ex-wife and I just happened to drop her going down the stairs. And that was probably willful misconduct and I'd probably lose that case, okay? So they have to, and people get sued all the time. Fortunately in EMS, we don't get a lot of them, but it does happen. Confidentiality, absolute. Cannot talk about patients outside of caring for them or outside of quality assurance, which is part of that evaluation I mentioned earlier. We have the HIPAA laws, you know, that it's a federal problem. If you run a call and it's somebody you know from down the street, and then you go to the local bar after the call and say, hey, we just took Jane to the hospital. Guess what was wrong with her? Oop, big time problem, okay? That's federal violation, okay? Confidentiality is absolute. The crew can talk about a call if they were on. Technically, you cannot go back and talk with the other people in the fire department that weren't on the call. Technically, you cannot do that unless it's part of a definite quality assurance process. That's allowed. We're also mandated reporters for child abuse. If you're not already a certified mandated reporter training certificate of some kind somewhere, you will have to take that online. It's free through the New York State. It's about a 2-hour online course and it's interactive, which means every few minutes they ask you questions to make sure you're still watching. And then you take a test at the end and then you have to bring me a certificate. That's required. We also have things called advanced directives. You may have heard of things like do not resuscitate orders, things like that. We're only allowed to accept non-hospital do not resuscitate orders. And we cannot accept living wills, you know, things like of that nature, because they're not recognized under law. And again, when we talk about communications and documentation, I'll talk more about advanced directives, but we can honor things called non-hospital do not resuscitate orders. There's also something called a MOLST form, which is medical orders for life-sustaining treatment, where they can say, don't intubate me or don't do CPR. That's signed off by a physician. And if it's somebody that we're taking like from a hospital back to a nursing home, and they have a hospital do not resuscitate order, we can honor that while they're still on our stretcher. But we'll talk more about that down the road. And just a quick word about crime scenes. These are difficult. We don't enter until it's been rendered, the scene's been rendered safe for us. We're not trained in subduing suspects and, you know, disarming people like the officers are, okay? When you do go in, try to remember everything. Don't move things unless you absolutely have to. If you're gonna cut clothing off somebody that's been shot or stabbed, do not cut through the hole from the stab or the bullet wound through the clothing. And just remember everything. And you, a lot of us go to court to testify for things that we've gone to. I've gone 4 times, 3 times in county court and once for a grand jury. So remember those things. We talk about documentation, document everything, because some of the cases, 2 of the cases I went to were 4 years prior. They were civil cases from car accidents. So you never know, okay? So just that's just a quick word about crime scenes for the moment. All right, so normally we would take any other questions at this time. Obviously this is recorded. So we will be Thursday having a live Zoom session. So bring any questions that you had regarding this lecture that we just went through, and we'll handle those first thing. We are planning on doing quizzes or tests based on these virtual lectures. Every time we get together face to face, we're going to split the class up, and some will be taking tests or reviewing some of the lecture material. The others will be doing hands-on, then we'll flip-flop you. On Thursday, will be a live Zoom session. I'll be talking about medical terminology and a whirlwind tour of anatomy and physiology. I don't know how long that one will last either, but I'm guessing in the neighborhood of an hour or so. All right, and we will see you then. Have a great rest of your day.